So the last, a bit shorter lecture that I would like to give you in preparation for the Lima course is a lecture on diffuse diseases of the liver. That is a difficult topic, especially for the beginner, because the diffuse changes are hard to recognize, hard to see. Nevertheless, we think it is an important topic, and at least we want to give you a primer on these diseases. Before we look at the diseases, I want to remind you on the anatomy of the liver, and in particularly because that is important when we talk about cirrhosis, which is the most important part in this lecture. I want to give you remind you about the anatomy of the vessels of the liver. There are basically two vessels. There are the hepatic veins. These are the more rectilinear, oblong vessels with almost no margins between the vessel and the liver tissue. There might be respiratory fluctuations of size, well, and their course is towards cranially towards the confluence where the hepatic veins confluent in like a star formation towards the right atrium. Look at it in a typical example for an ultrasound. This is the very long. If you see on one image, you can see almost through the whole image, you can see the linear vessel. And if you want to compare this to a tree, then it definitely compares to the course of poplar tree. Acute angled branches. Keep that in mind for recognizing hepatic veins. And then there are portal veins. They are far more branched in a almost right angle. They are often only intersegmental in one plane. They have an echodense margins, which we might call like an embankment of a river that are surrounding them. If we look at an example, this is a typical portal. See 90 degrees, then this is a branch going towards the left and a branch going toward the right, and you see the echogenic material, small amount, but still it's almost always visible. Echogenic material, the embankment, and if you again want to compare it to a tree, then a willow tree is probably the best comparison, again without leaves and again against the still depressing winter sky. So that I just want you to keep these in mind, and because the vessels are key to recognize liver disease. What is the differential diagnosis of diffuse liver disease? It's obviously long. Fatty infiltration, hepatitis, cirrhosis. Then we have venous congestion, we will not deal with, but Chiari syndrome, rare but visible. Schistosomiasis, if you're in the right area. Rare storage diseases, there is a wide variety, but the main, let's say, are the first three. Let's have a look at the ultrasound signs of fatty infiltration. Normally the liver is increased in size. It has a smooth surface. It is the caudal angle is very, it's obtuse. It is increased in echogenicity. The liver might even appear completely white when more than 50% of the cells have fatty infiltration. And due to this whiteness, due to the increased echogenicity, the posterior portions and also the vessels within the liver are difficult to see. So if we look at an example, so here you can see a large and very echogenic liver, basically. That is an example of fatty infiltration. Here, another example, you see it's relatively echogenic and you hardly can see any vessels, hepatic veins or portals. Another example here, this case, you can see it has a smooth surface, it is very echogenic, you can hardly see any vessel that is surrounded by ascites. Ascites, as we will see later, pointing you a little bit towards cirrhotic liver disease and the sequelae like portal hypertension. But if you look at the surface, it is a very smooth and flat surface. Hepatitis. Uh, Hepatitis actually is, from an ultrasound point of view, one of the most boring diseases. There are no specific ultrasound signs. Normally, the liver looks normal. There might be decreased echogenicity. Well, you don't know how the liver looked beforehand, so this is very difficult to say. Right portal vein radicals are described. Lymph nodes around the portal vein, that's maybe the only sign visible. Splenomegaly accompanying it, but usually not a marked. With chronic hepatitis, there might be then a bit coarse echo pattern, coarse, all very subjective. This is a patient with acute hepatitis, and you can see that it looks like a liver. You can see that the spleen is a little bit enlarged because it's a viral disease, but it would be enlarged in any other viral disease as well. So not really much to see in. If you look at the literature, there is data that this, particularly this lymphadenopathy and chronic hepatitis, can be considered as a diagnostic element, as a predictive element. Maybe here you can see again this node in the portal area, single node only there. You remember from the lecture about extrapulmonary TB, there were multiple nodes all over the place. This is here only very periportal. And in some studies, researchers found that the volume of this node can predict the severity of disease. I'm sure that that works in a in a very special setting, but in general, I think ultrasound does not really help too much with the diagnosis of hepatitis. So then let's come to the most important thing. Let's come to cirrhosis. What are the signs of cirrhosis in the ultrasound? The right lobe tends to shrink more than the left lobe. The caudate lobe, from the vasculature being part of the left lobe, is enlarged. The portal vein, due to portal hypertension, might increase in size. The vessels, and I will talk about that. The portal vessels have a sudden decrease in caliber, and the vascularity in general is decreased in the peripheral liver. If we want to make it simple, and it is a complicated diagnosis, so at least we have to keep the criteria simple, I would recommend to remember ultrasound for cirrhosis is I want to look at four things: the surface, the echo texture, and this one I would even put in brackets maybe, the segments, and the vessel. Let's look at these individually. The surface. This is our standard normal liver. We can see the surface is smooth. Obviously, with the cirrhotic changes, and if you can see the surface nicely, like here, you can see that it is nodular, that it is bossylated, that it is irregular surface of the liver. And I remember in the last course in Lima, we had I used the word bossylated, which I like very much. I don't know why. So, but nobody seemed to really understand that this is an English word. So I had to look it up and found that it is an English word. It is modified from the French bosselé, which means covered with multiple small protuberances. So if you enlarge your image, you can see there is a fine, irregular protuberances. Maybe in comparison to the nodular, which is more, nodular seems to be the proper term for it, I admit, and it is made of small round nodes, and you can see this is a nodular. It describes the same thing. The one is maybe finer than the other. Then the echo texture. That is a bit of a difficult thing to see. Again, we have our reference liver, and you can see here that there is irregularities. If you are not used to ultrasound, if you are not used to comparing livers or has its reference livers, it might be difficult to see that this is coarse. It is described, I want to mention it, I think it is the most weak point of this four. A good point is the size of the liver segment, and in particular the caudate lobe. Why is that? Enlargement of the caudate lobe is described as a very specific sign of liver cirrhosis. And to find it is actually very simple, because what you do is you put a longitudinal scan in the epigastric angle. You will usually find this scan. You will see the liver, the caudal pole, and then right in the middle there is this lobe here, and that is the caudate lobe, split by the ligamentum venosum from the rest of the liver. That is the caudate lobe. Actually, the participants of the last course here in Lima called this then the shark scan, because it looks, it does look really like a little bit like a shark nose. So then this lower jaw of But again, as I mentioned, the vessels. The vessels, I think, are the most important thing to look at. We have our standard vessels in cirrhotic liver. Due to the nodules, the vessels become irregular, they become meandering, they become curved, and as mentioned before, they become amputated. And let's go back to our botanic session. This is a cirrhotic tree, you can say. It is cut, and then you see this small new twigs springing from the trees. That would be a cirrhotic tree. How does that compare to ultrasound? Basically, this you can see here is the trunk, and then the smaller. It's like amputated here and there, and the smaller ones are hardly visible or very compressed by the stiff cirrhotic liver. Again, it basically breaks off with a bit of echogenic fibrotic material. These are signs. Again, another example here, you have a bit of ascites as a sign of pulmonary hypertension. We have a bit nodular surface, and then we have these amputated. Often the central veins are a bit enlarged due to portal hypertension, but then the periphery is obstructed and compressed. What are other possible secondary signs of cirrhosis? Well, I think you know them all from the internal medicine books. Ascites, of course, splenomegaly, collateral veins. There is the patent umbilical vein, which is often visible, which forms the caput medusae under the skin. Then splenorenal shunts, splenogastrial shunts, a bit more difficult to see. And one thing I want to mention is the portal vein cavernoma. I'll show you an example because that is frequently seen in ultrasound. And then these are, well, this is again due to hypertension in the abdominal vasculature, edema of the gallbladder wall. So ascites, as we mentioned, irregular surface, nodular surface, not bossulated but nodular. And another example then in a patient with cirrhosis, this is the spleen, and we can see it is definitely enlarged. Here's the kidney in comparison, so this is a huge spleen. And if you put your transducer in the middle and in the here, you can sometimes see this. This is the spleen, and this is the tip of the left lobe of the liver. This is what we call the spleen-liver kissing phenomenon. Basically, the two touch in the middle of the abdomen. So that's a sign of splenomegaly. Portal hypertension, can we see it in the vessels themselves? Normally, the portal vein is smaller than 13 millimeters. If it is increased above 17 millimeters, and that's not always the case, but if it's the case, then it is suggestive of portal hypertension and an increased risk of esophageal varices. If you don't see it enlarged, it does not mean that it is not hypertensive. If you have the possibility of color-coded ultrasound, then of course you might see reverse hepatofugal blood flow. This is the normal portal vein. This is an enlarged portal vein which is directed over here towards the spleen. So this is an example of portal tension, and this is what I mentioned earlier. If you see the portal here, usually in the color Doppler, red is blood flow towards the transducer, blue is away from the transducer. So here in the portal we have blue flow, we have flow away from the liver. So that is of course a reversed inverse flow compared to the due to hypertension. And this in the liver, relatively often, if you look for it, see these portal vein cavernoma, these dilated vessels, connection between the portal and the hepatic vein. So there is a dilatation of the vasculature in that area, which is described as cavernoma. Of course, it's not a tumor, it's just the description for this. If we have Doppler, as mentioned, then we might see here in the spleen area, this is the spleen, we might see these splenorenal shunts because basically the portal hypertension leads to flow in that direction, and then it opens shunts towards the kidney. So this in these advanced stages and in these advanced cases, you can see these shunts, and then of course this is accompanied often by splenomegaly and then with ascites, and then if you have the full-blown picture, it becomes easier to recognize cirrhotic liver disease. In beginning, in early cases, it might be very difficult. So I think that's all I wanted to say about this. As I mentioned, finding the diagnosis of cirrhotic liver is difficult, and I remember my consultant long time ago saying to me that ultrasound is not the tool for diagnosing cirrhotic liver. It is in the end a histology diagnosis. That's, I think, still correct. In many cases, as I mentioned, in advanced cases, you don't need that because the signs are so sufficient. But in the end, to rule out cirrhosis is also very difficult with the ultrasound.